Okay, so here's my gear list of what I use. Today we're using a Bard Power pick line, 4 French, 55 centimeter. I like to have extra surgical towelettes to open up or expand my sterile area. We have markers to be able to mark the sites, and I'm gonna throw this in my sterile field. So if there's any markings that came off during the cleaning process, I'm gonna use this to remark the site. Plenty of sterile gloves. We're using the butterfly today for the ultrasound imaging. We have 2 generic Civco probe covers. We're gonna use that to cover our non-sterile cable. And then we also have our sterile cable. And I'm gonna show you how to use both in both scenarios. This is our EKG machine. This is our secondary EKG machine. This is the C3 Wave by Angiodynamics, not Medcom. This is an old device. This is the cable that comes with the Medcom for EKG confirmation. And we have, of course, EKG stickers for the patient. And then extra sterile saline because I'll be by myself and won't have anybody to assist. This is our 20 gauge. I like using these instead, but we're gonna see because this is a very different insertion. However, this helps me to not be worried about perforating the needle as much. It reduces the risk of perforating with the needle. So I'll show you how that works. And we have a blunt needle to be able to draw up the lidocaine for the tunneling. And this is a 30 gauge, very tiny needle so the patient doesn't feel it as much. We have a 14 gauge angiocath we're going to use off-label for tunneling the PICC catheter, and we have 2 10 milliliter syringes for the lidocaine. And then here we have, finishing out the procedure, we have our bio patch, our Masticel for the dressing. We have our needleless anti-reflux needleless connector, TKOs. We have the SecurAcath exofin to close up the incision site for the tunneling. And then I'm gonna use this for extra. I ran out of chlorhexidine wands, so I needed to pull from this kit. I may use stuff in here, we'll see. This is it, what I'm gonna use for tunneling today. We have a patient here who has long-term antibiotics, over a month worth of antibiotics and PPN that needs to be delivered, which is going to be caustic to the smaller veins. However, nephrology has asked us not to access the upper extremities, so we're only going to access the IJ here. We're going to tunnel it out for the long-term access. Now, the patient has a looping EJ. This is very inconvenient because we can't tunnel with traditional tunneling, or else we're going to perforate that EJ, and that's going to be a big problem. So we're not going to do that. However, we are going to do a pseudo tunnel, needle subcutaneous tracking, basically needle under the EJ and try to get to that IJ spot. Okay, so let's take a look at the anatomy and see what we're working with. We're going to try to visualize the IJ, the target first, and then we'll worry about the rest of the other anatomy. So let's figure out where we're going to go. So there's the IJ, nice and prominent. I don't see any. So we could tap that from the skin right there. And I don't see any other, besides the muscle, I don't see any other issues here. Okay, so the EJ is right there. So you can see that the EJ is about, I don't know, 1 to 1.5 centimeters apart. Let's actually measure that. Actually, we can measure it right here. So from here, from that center, we have about a, let's move, yeah, the edge of the IJ, it's about 1 centimeter to the EJ. And so what I'm gonna do, and I'm looking for any collateral tissue or objects that I don't, or tissue that I don't want to perforate with the needle when I'm tunneling. So it looks like I can go under. There doesn't seem to be another structure. Oh, maybe that one right there. No, just a shadow. Okay, so let's make sure looking at it long view. Actually, let's check it biplane. So we have the EJ here. And we need to tunnel underneath it. And I see a vein underneath. But it's more inferior. So let's see, worst case scenario, at this junction, so we have about a 0.8, about a 1 centimeter distance. We'll get out of biplane view because not many people have that function, so we're going to not use that today. We don't need to go too deep, thank goodness. So once I tap the EJ here, I'm scanning it. There's a small collateral vein there that looks like it might conjoin. With that EJ, but it's to the side, not under. Oh, it's a little bit underneath, so we have to be careful with that as we're tracking the needle. And again, superior. So what we're probably going to do is tap the vein here, and from here we're going to tunnel out to right about there, So I just want to make sure that when I'm needling, because I'm going to needle this way, probably actually this way to give it a little bit more curvature. I'm going to needle this way. I'm going to go underneath and make sure I dip really deep and go underneath. So I want to, before I hit this plane of the EJ, before I hit that plane, I want to make sure that I'm sub 1 centimeter. So I need to make sure I'm underneath, and I'm going to bend the needle probably ahead of time. And then we're going to try to continue on. I see no other objects that will get in my way. And then we'll hit the EJ from here. Okay. And then we'll use the 6.4 centimeter angiocath. So what I'm going to do is start close to the EJ, right next to it, so I know that I'm not going to hit it. Actually, probably about 0.5 centimeter back, and then we're going to enter that way. And then we're going to 6.4. It's barely making it. Oh, with that angiocath, it can curve with the veins, so I think that's going to be the move. So we'll do that. So that's about oh, that's gross. About from the 4.5 to 5 centimeters where I'm going to enter, and then we're going to enter into here. And then we'll remeasure for the subcutaneous tracking afterwards. Yeah, I'm going to put a wedge under her to give me more room to needle that tunnel. But let's take a look at what our anatomical measurements are going to be. So if I'm going to try to end here, and then we'll remark that after we clean it. Our EJ's here. We're going to have to needle from here, and then we'll probably tap it at about here. And we're going to go underneath and hook underneath that EJ. And then what is going to be our final length of the catheter? Now, if her EKG and her P wave, which I saw her 12 lead, had a very prominent P wave, we're not going to have to worry so much about the measurement. But let's do it now. Get a good, actually, yeah, because we're tunneling, we need to get a good clear measurement of our location. So this is a tricky one. We can't tunnel it out to here. And I'm going to have a very hard time inserting from down here low because of the clavicle and the EJ. So we're gonna have to go from here, tap it this way, and then tunnel it out to a safe exit site. Okay, so you want to measure from your intended exit site. Let's see, from here, it does dip down a little bit to about, let's say, 18 centimeters. And then 1, 2, 3 intercostal spaces lends us at about 28 centimeters. 28 plus the SecurAcath, 1, 2, 3, 31 centimeters. So let's try that again. I like to remeasure, especially for something like this where the measurements make all the difference. Let's say from here to here, still at about 10, let's say 11 centimeters. From 11, 20, 1, 2, and 3. Let's try that again. That was a little bit different. So we got here to here, it's about 10. From 10 to the right clavicular joint, about 19. From 19, 1, 2, 3. So I'm getting about 29. I'd say 29, 1, 2, 3. So I'm getting 32. So 31 or 32. I like to, because I have a SecurAcath, I can actually afford to be longer. So we're gonna shoot for 32. Let's make sure. So from here to here, let's add 11 because of the turn. That's still about 20. 1, 2, 3. So we have about a 29. Let's say 33. Yeah, let's go with a measurement of 33. So we commit to that. And then let's get prepped and started. Put these leads on her. So same lead color placement standard. Your fire, your red lead is going to be the chest on the left side. Sometimes a closer up. There we go. Like the more medial, it helps to read it a little bit better. And then of course, smoke over fire. And then we're gonna put this white lead last over here on this side. So we're gonna look at her baseline and see what she's got. And we're gonna compare it to our EKG, handheld EKG, to compare the two. There we go. So we're gonna check her EKG. We're gonna hold this middle button until the light blinks. And then when the light turns on, you'll get our EKG. So here's what we got. We got a weak R in the QRS complex, but we have a pretty confident P wave. So let's capture that with the C3 wave here. Okay, we're gonna capture that. We've got a good P wave right there. We got 2 good P waves. So that's gonna be our baseline. And our measurement is, what do we say, 33? Uh-oh, I wonder if the battery's dying. Battery could be dying. Why? Okay, so here's our P wave. We got 2 pretty good P waves there, very prominent, very clear, very consistent. Okay, we've got a measurement of 33. All right, let's see here. We've got about the same wave, so we're gonna keep that. I'm gonna move this out of the way. So we're gonna connect it ahead of time, move this out of the way, and I'll show you how to maintain sterility, maintain ANTT during the procedure. So another thing I wanna show you guys, before every chest insertion, you want to do a lung scan. You don't need a special lung scan for this. You can use your regular linear ultrasound. There we go. I see nice movement. So sliding lung positive. Before I get my hands bloody, I'm gonna use this extra probe cover to grab my non-sterile cable and cover it so that we maintain sterility with this. Then we cover it just like we would with the regular EKG probe, and then use it later. Another option is to use the sterilized packages, the sterilized cables, and hook these up later, and I'll show you how to do that with these. And these extra sterile pieces, I hold on to these so that I can use them to grab non-sterile items outside of my field. As an emergency, last resort. And there's our dot. That EJ is very prominent now. So we're going to try to go underneath the EJ and then get to the IJ from there. That way we know where not to come out of and where not to perforate. Okay. Then here's our intended exit site. So to differentiate between the different chemicals, I write it down, make some marks all over so it's very clear what it is that's in each syringe. This will be the benzyl alcohol. We'll start with this, and I'm using the 30 gauge, very, very tiny needle to start my injection. That way the patient doesn't feel so much of the pain. The med comp is in here under this part of the drape, so I'm going to puncture. So we're going to go from here down this way. Local anesthetic. Very small intradermal wheel. It doesn't need to be that big. Okay. So I'm going to bend the needle a little bit. That way we have a little bit more leverage. We're going to insert at about here as well. Just a little bit. Just to get things going. Very slow. Okay, baby. You want to stay intradermal and not subdermal. Basically like a TB test. Okay, and so the rest of the way I'm going to use lidocaine to anesthetize it even better. The more potent medication like lidocaine. Alright, so I want to anesthetize this area too, just a little bit. And then we're going to give that time for that lidocaine to kick in. And then we'll keep going. I'm going slow on purpose. I don't want to wake her up. She's still dazed from the Ativan, and I don't want the pain to undaze her. Minimal dissection. And another thing I like to do that I forgot is I like to mark my track of where I'm going. Basically helps to keep that lidocaine in track. So, there we go. One. So reinforce the numbing effect with that lidocaine. Okay. Now we're going to use a longer needle. All right. Which is going to be our introducer needle. With the introducer needle, we need to have a hard bend to make sure after we're underneath, we hit the vein itself. I'm going to anesthetize on the way down to the vein. Now I'm putting a lot more than I need to, or than usual, because I need to compensate for that curvature of the anatomy. So we're going to go underneath the vein. Let's find the vein first. Find that needle tip. Is my puncture away from any? There we go. We're going to go deep. There's my needle tip, about 2 centimeters deep. Ooh. Let's go further back. Let's find, there it is. There's my needle, and I'm tracking it down. There it is. So I'm trying to avoid by going deeper down. Tip seems to, there's my tip. So I'm going to duck underneath that EJ. Closer in. Let's do this until I get close. Actually, I do want to dissect it with Lido. Make sure she doesn't wake up for the... Let's find our needle. There's our needle. Inject a little bit. No, baby, there's a little burning, I'm sorry. Put down some more. To about right there. Scoop underneath. There it is. There's the length of my needle. There. So we haven't passed the EJ yet. Ooh, almost. There's my needle. I'm going to go further in. There it is. And scoop underneath and make sure there's nothing else in the way. Make sure I'm not snagging anything. I didn't perf anything yet, but it's a little too close for comfort, so I'm gonna go even steeper. And make this line up. There we go. Make this line up beautifully. There's my needle. There's my needle. I'm going to keep driving it down deep. There it is. Nice lidocaine dissection. There's my needle tip. So I'm under that EJ. So I'm going to turn up. There it is. So I avoided the EJ, and I'm past the EJ now. Put light pressure to see if there's anything I'm compressing. I don't think so. I'm going to go straight, like so. And then dissect a little bit more. Get a little light on there. Before I advance, I'm going to find my needle again. There it is. All right, so we're going to pitch it back up towards the IJ now. There's that little lymph node, it looks like, possibly. So I'm going to avoid that. Let's find that needle shot. There we go. And then we're going to try to tap that. Okay. There's my needle. Where's my tip? There's my tip. Okay. There's my needle. So I'm going to scoop up. Let's find my tip first. It looks like it's about to poke whatever that little object is, so we're going to avoid that. A little tension. Little dissection. There it is. So there's my needle. There's my vein. I'll be very careful here, because I do want to insert from here. I'm taking my time, no rush. Find your needle tip, then move. But don't move until after. Let's turn up, rotate the needle up. Okay, there it is. Oops. That's why getting a handle of your probe is very important. As you can tell. So I want to get the length of that needle. I trust the image. Find that tip. So you have to rotate it properly to see it. And we're underneath. Okay. All right, let's find that tip. Right there, so if I advance it forward. All right, we're about to puncture. I'm going to lidocaine that area too because it's quite sensitive probably. All right, so it's coming up from underneath. There it is. Gotta get rid of all these bubbles. There it is. So now. I'm going to advance my catheter so that the catheter will do all the work of bending into and down into the vein. Okay. There we go. Nice, good blood return. Now, one thing I want to make sure that we're doing is going down and not up. Yes, beautiful. It's going down the right way. Okay, so we went under the EJ. What I'm gonna do is, since we have access with the Guidewire, I'm gonna rely on that and not on the catheter. This will allow extra gauze. Let's clean up that wire, clean up that site. Okay, so now we've got to tunnel it all the way out. So we've already anesthetized that area. Now we've got to nick that area. So now we have to nick that area. We need to make sure we nick away from the EJ. Okay, and then get our tunnel. We're gonna bend it so that we have more leverage to dig into. Look at that, patient won't even feel it. Okay. Now, if you're concerned, while you're starting, if you're starting out with this tunneling and you're not sure about whether you're gonna perf, the wrong thing, you're more than welcome, of course, to use the ultrasound to guide your needle. We can find our 20 gauge, we can find our, there we go. So you can see where it's at, right there, and then just keep going. Remember, you don't want to be too shallow, but here it is, there. So you could guide it all the way down if you'd like. Now we want this needle to come out of. Now what I'm doing with my pinky and my ring fingers, I'm grabbing it so that I can control the direction of where that bend is going to go. Then let's make sure we get out of the tissue properly. There we go. Now most people nick first, but because of her issue, and you want to use a scalpel so you don't poke yourself. How about that? Let's take this back. What I'm going to do with this is I'm going to put this gauze through it and then hold it down with the gauze so it's out of my way. There we go. And then let's make sure we come out the right. Avoid the vein. There we go. I want to make sure I'm coming out at the same area as the guide wire, or else the tissue. There we go. Okay. So I'm here, measurement of 33. So we're going to trim the 33. So we have a guillotine. And what you want to do is look for the hole, and you'll be able to see where you want to cut. So we're going to cut at the 33, and about there. I'll pull this back to make sure I'm really not caught. It's not a fun day to trim the stylet. So I'm going to show you two different ways you can obtain EKG confirmation with alternative EKG technique. This is off-label. Okay, so I'm going to pull this out. I'm going to feed this through. I'm going to come out. Oh, I forgot about that. So because of the way it's oriented, I can't pull that out, so I have to cut it. Don't lose that, that'll suck. So now we have our tunnel, and I like to hub it all the way just for now. And then we're gonna apply the MST dilator. I'm gonna use this. Have this go in. Nice and smooth, coming out very easily. Give it another clean now. I like what some people saying, which is we should re-glove. I should have re-gloved it before handling the catheter. So why not wipe it extra? Okay. So now we're going to pull the guide wire and the dilator out at the same time, and we'll get some amount of blood here. So we're going to catch it like this. Then we want to close that up as quickly as possible. Okay. Go down. There we go. All right, so got this getting fed in. Let's see if we can get an EKG from this. I don't think we can, but just in case, let's give it a try. So here is the sterile way to do this. Got an EKG, and then, so what I like to do is just very carefully, well, perf to start the opening. There it is. So I like to get a little bit of the teeth out and then clip. And then I cover it with something like this. And I'll keep this in here. I'll keep it nice and protected. Now we want to make sure that we have a complete saline column. No P-wave amps, so let's see where it went with the ultrasound. I hope it didn't try to curl up. It could also be that we're not in deep enough, so we'll see. Okay, dilator's going down. Good. Going the right direction. So is the catheter. Okay. Okay, so the catheter is going the right direction. We have the catheter in. So what I'm going to do is at this point, we can't control which direction it goes while it's in the body that far deep. So we're going to do that. And then what I like to do also, in case I need to pull it back, let's see where the SVC is going to go. Let's give it another shot. See what that looks like. Are we getting any kind of P wave change? If we are, we're going to commit. No P wave change. I wonder if it's barely in there. Okay, so at this point, we have to commit. And if there's any things, if it's deviating like across the chest, then we can, hopefully we can flip it, but we're going to push this as much as we can and through. Now it's very difficult because, oh, we gotta get the guide wire or the stylet out all the way. Okay, after the stylet's out, we're gonna push the rest of it in, and then just shove it in there. And we're gonna pull this part out just a little bit, a tiny bit. Not too much, because I do want this to go in the neck the rest of the way. Okay, so at this point, we're going to disconnect that, flush, give it that flush, clamp it, and you can either feed that stylet back to get closer to the cavo-atrial junction of the SA node. It's feeding really well, which means that we haven't, at least I don't think we've really hit too much of a curve. Okay. All right, let's see now where we're at. Please give me an elevation. If not, we'll have to see where it is. And I don't think, well, we're pretty much committed. So I'm gonna try to see if I can follow it up the track with the ultrasound for now to see if there's anything else I could do to finagle this, which I don't think I can. I really hope it didn't double back. Looks like it might have doubled back. Wow. All right, well now I gotta flip it. Let's do this. Let's commit to the tunnel and let's try to flip it. It looks like it went in and then it doubled back out somehow. Maybe a valve, not sure. Wow, okay. So we're gonna apply the SecurAcath and then we're going to try to use pressure to flip it out of the IJ and into the SVC. We'll see what we can do. So you want to make sure that this feet goes in subcutaneously. Looks like the tissue's kind of thick, so we're going to use our dilator. It's almost a good insertion. Just going to go get through that fascia. You heard that fascia band. Yeah, we're going to get underneath it. There we go. The feet, if you can see here, the feet are nice and straight. They're not crossed. So this is a good placement. We're going to pull by 3. 1, 2, 3 for our initial measurements. And then we're going to clamp it down 1, 2, 3 centimeters out, which should help to straighten it out. So we're anchored in. I'm going to tape it down in a second. What I like to do is re-scrub each opening. Just give it a little extra clean. I want to keep the wire in here too so that we can observe where it is on the x-ray a little bit more easily. So you notice that I crimped it earlier. Actually, I might not have shown you, but I crimped it earlier to match the length of the catheter cut so that I know when to stop when I feed it back. All right, so we want to make sure that I like to double clean before I commit to my dressing and my glue. Yeah, I'm going to massage this area. Hopefully it'll help. Another new set of sterile gloves before we lay down the dressing. So this is the Exofin skin glue. I'm going to apply this, twist it till it punctures, and then we are going to pinch the skin and then apply the glue. I want to make sure, it's all over. Got a little zealous with that glue. You only need a few drops, but we'll pinch it continue to pinch until dry. That way it'll hold the skin in place. I may do the same thing with this one. We'll see. All right, so how am I going to mitigate this? It's double back up in the IJ. What I'm going to use is I'm going to sit her up straight, and I'm going to use 3 cc syringes to hyperpressurize and flip that catheter down. This is not in the IFU, but this is a troubleshooting you can do. These polyurethane catheters are pretty stable. You're not going to be able to blow it as long as it's fully patent. So we're going to do that to flip it down towards the cavo-atrial junction. Let me see if I have enough glue for this area. So what I like to do is pinch. You still need to pinch the skin, pinch the tissue closed. Now let this go a little bit. Pinch it closed, and apply the glue. So I'll pinch at that site. Pinch at the skin to prevent the blood from oozing out, because blood will mitigate the efficacy of the glue. Hold that pinch. Let that dry a little bit more before the biopatch, because I don't want the biopatch glued on there. And let's get our dressing ready, we might as well. Have to put this underneath, get that closed up. Okay. Let's dress that first before we clean up the mess. All right, so we're gonna tape this back here, so like so. And grab. Now you do not want to crack it like I just did. You want to use gauze or something to protect yourself in case the glass punctures through the plastic, although it's never punctured in my skin before. I do live on the edge. Okay, so this should help with the adherence of the dressing. All right, so we didn't do anything actually. All I did was sit her up all the way, and it seemed to have resolved the EKG issue. We're gonna go ahead and check the surface and check this one. So we're gonna compare the two EKGs to see what they look like. And then of course, we have our C3 wave connected here and our generic EKG machine connected here. Okay. So here's our baseline EKG. So I see the QRS, and I see that P wave. That P wave is pretty well elevated, which is good. Now let's look at the internal. So for the C3 wave, this changes the function to the internal ECG, and that looks like a pretty good P wave elevation there. Now, the EKG, I'm gonna give it another saline column. The EKG on this monitor looks a little bit better. It's a lot more clearer. Right. What we see here, what's going on? That does that funky thing. So turn it on, turn it back on, turn it off and turn it back on. And then we're gonna flush again. Okay, that P wave looks great. Yeah, that's an elevated P wave. That's fantastic. It's pointed down, so we can use it. So of course, at the end, we want to check for sliding lung. I don't watch that little node or whatever that is, that tissue. There it is. See how I slid back and forth? So you can see that there's an EJ that is kind of looped the circle around the IJ. It's basically like a force field. We needed to tunnel this out, and I couldn't tap it medial to that EJ. And so I was trying to figure out how to tunnel it out to somewhere safe for long-term antibiotics. So what I ended up doing was hooking the needle, bending the needle, starting lateral to the IJ, and then feeding that 6.4 centimeter angiocath through, took a turn and hit the IJ here while starting underneath the EJ. So I went under the EJ, hit my target, was able to thread the rest of the angiocath through, and the angiocath was able to bend to the direction of where it needed to go. And then I was able to safely tunnel it. Out to here instead of being so dogmatic and trying to dress it down to the chest like the traditional tunneling. So this is a very interesting case where we had to tunnel it out to where the shoulder was and or lateral to the EJ to avoid any complications during tunneling. So this video was probably one of the hardest ones to edit, not because it's any particularly difficult editing process, but because I keep looking at this picture over and over and over again, this particular EKG, and I'm kicking myself because I missed this blatant STEMI, this ST elevation, very clear in my face, and I didn't catch it at the time. I wasn't there to assess for chest pain, shortness of breath, diaphoresis, syncope, or anything like that. I was only there to place the line. Patient didn't present with these symptoms, and the context of where I was hyper-focused in was trying to place this line. That's it. And the patient had Ativan before I got there. They had plenty of comorbidities that just complicated things at that time for that procedure. But it keeps eating me up inside that years after I did the procedure, because I didn't look at this or start editing it until much later. This was years ago when I did this. Now I see that I completely missed that STEMI. So, and I'm not saying that if you're doing these procedures, you should be catching the STEMIs, but it's something to consider. As an ER nurse, I was terrible at EKGs back then, but even as an ER nurse, I noticed the STEMI myself during the edit. But I was so hyper-focused on that P wave that I didn't catch it at the time during the procedure. Again, a cautionary tale, just a reminder that this should have been reported, but I didn't because I didn't catch it. I didn't notice it because I was so focused on the procedure itself. Not telling people that you should have caught it, but I think it is a warning for us doing these procedures that we should be aware of these EKG abnormalities, because I should have caught that STEMI and told them, hey, you might want to investigate further. I noticed a STEMI on my EKG assessment. You guys should do a 12 lead as well. This doesn't guarantee that the patient had an MI. They had electrolyte imbalances. They had, even the QRS is abnormal. And so they needed a 12 lead to get a really good picture of what was going on. But whether it was a true MI or not, we won't know. But, something to consider in our specialty community, maybe we should be, because we're using this assessment tool, maybe we should also be assessing for knowledge on the EKGs. Standard abnormalities like STEMIs, blocks, things like that should also be in our repertoire of knowledge. So just something to consider when you're doing these things, that there is another thing that you can level up your skills and your knowledge with to make sure the patient gets the best care.